don't have any disclosures. Don't forget our favorite Twitter handles. And for our viewers on YouTube and Livestream, please subscribe and follow DeBakey Institute for Cardiovascular Education and Training for current updates in cardiovascular sciences. And a special thanks to Dr. Zagbi and Dr. Faisal for sharing some key slides. And remember, please mute yourself if you're not talking. And of course, we are going to base our discussion today as directed by our guidelines, both the valvular stenosis guidelines from 2009 and the more recent updated guidelines in 2017 on aortic stenosis, which actually delves into a little more specific details and challenges in the multimodality assessment of aortic stenosis. Well, I just want to see if audience want to pick their favorite. You want to start with mitral or aortic stenosis? I think, I'm being trumped by the mitral one, so I'll go with the mitral stenosis. So some interesting fun facts in history. Mitral stenosis was first described by Dr. Vucens in 1705, and he called it a bony transformation of the mitral valve. It was actually the first valve lesion treated with surgery in 1923, and the first ever valve disease actually diagnosed by echo in 1968. And it was actually the first ever valve lesion to be treated successfully. And here is actually a very cute video. Now, let's talk about what do we know in 2021. And Jeopardy enthusiast, keeping it quick. It's a rapid fire question series. So please jump in, and if there are any takers, please unmute yourself and answer the question. So starting with our first question, and let's look at the next question. How about this one? Severely dilated left atrium, most commonly from severe mitral stenosis and sometimes associated with dilated pulmonary artery, is called the Ordner syndrome, right? It's actually the cardiovocal hoarseness typically caused by the recurrent laryngeal nerve paralysis. All right, the last question. This pattern of cyanotic red and congested cheeks seen in mitral stenosis is called? Any takers? It's actually called Mitral Facies, right? I think it was a simple question. So moving on, here's an outline of what we're going to talk about mitral stenosis today. So, right, we're going to briefly talk about anatomy and some causes and anatomic presentation. We're going to talk about valve area and other indices of assessment of severity, and also summarize it with grading and management of mitral stenosis. So everybody, all of us know about the typical anatomy, right? 4 to 5 centimeters in area. It includes the mitral annulus, which is actually saddle shaped to reduce the stress on the leaflets itself. And the next again is the anterior mitral leaflet, which is arbitrarily divided into A1, the lateral, A2, the middle, and A3, the medial one, right? And then we have our posterior mitral leaflet, which is anatomically divided into scallops. P1 is the lateral one, P2 is the middle one, and P3 is the most medial scallop. The chordae tendineae again are vital to remember that knowing and understanding the anatomy actually plays a very key role in assessment of mitral stenosis. And again, we all know this basic transthoracic views, which we use to assess anterior posterior mitral leaflets. And again, they are joined both medially and laterally to form the commissures. And here is a normal MO tracing showing the early filling and the atrial filling waveforms. Again, TEE is preferred for detailed assessment of mitral valve, given its proximity to the LA and also much higher spatial resolution. And again, 3D TEE obviously offers more incremental data about valvular morphology and anatomy. What are some of the common causes of mitral stenosis? Of course, right, we have to start with our classic rheumatic mitral valve disease, which is mainly characterized by commissural fusion and caudal shortening associated with leaflet and subvalvular thickening and calcifications with commissural fusion, decreased ENF slope. And almost the other characteristic feature you see is the parallel motion of both the leaflets throughout, because it's because of the consistent pressure gradient across the valve throughout hypertension, prior chest irradiation, CKD, atherosclerotic disease, and is associated with aortic stenosis, and we know is a difficult to treat disease. And then we have our inflammatory conditions, right? So some of the most common one is the carcinoid one, where you see thickened and tethered leaflets, which can typically result in mixed valvular disease. And it's mainly characterized by endocardial plaque of fibrous tissue deposition involving both the leaflets and the subvalvular apparatus. Left-sided valvular involvement is seen in 5 to 10% cases and usually should be suspected in cases with extensive liver metastasis or bronchial carcinoids and presence of an intracardiac shunt. And another one is also a radiation valvulitis. As you see here, there is definitely extensive calcification of the anterior mitral leaflet and the iotomitral curtain area. And then we have this large congenital cohort. Of course, we don't want to delve into the details. We have the supravalvular variants with fibrous rings and Schoen complex. Then we have the double orifice mitral valve and hypoplastic valves. And again, here's an example of a parachute mitral valve, and you see a single papillary muzzle attached to both the leaflets. And then you have the hammock valve, which is also called the anomalous mitral arcade. So evaluation of mitral stenosis in a methodical way is very important, right? It typically starts with analyzing the valvular anatomy and then going through various indices and severity, gradation, and then a little bit knowledge about associated lesions and modifiers, and finally, assessing key situations is very important. A thorough 2D assessment is a key component, and attention should specifically be paid to both the valvular and the subvalvular anatomy. And looking at the big picture is also very important. So moving on quickly to how to assess 2D imaging and valve anatomy on echo, right? So evaluation of anatomy is a major component because mainly we are looking at commissural fusion in addition to degree of valvular and subvalvular thickening and calcification. And as you all know, there are various indices which we typically use on echo. So one famous one, of course, is the Wilkins score, which is actually based, it's a score ranging from 0 to 16 based on the mobility, thickening, caudal involvement, and calcification. And we all know a score of less than 8 is preferred for pliability for a balloon valvuloplasty. Other popular ones are Cormier score, which is actually a more simplified version in combination with fluoroscopy. And there is also real-time 3D echo-based scores where actually each and every individual scallop is assigned a score based on the thickness, mobility, and calcification and come up with a better cutoff for pliable results. The next one is, of course, how do we assess severity, right? That's the most important thing we do on echo. Definitely based on pressure gradients, mitral valve area from Claymetry, pressure half-time based mitral valve area, and continuity equation-based mitral valve area. A little bit about PISA method and few important other indices. Pressure gradients, right? The key to assessment of mitral stenosis, particularly the mean mitral gradient. So the gradients are usually obtained by averaging the mean instantaneous velocities, which thankfully is done by computers these days. And it's actually backed by robust data from 1990s. We all know that Doppler gradients are definitely comparable to cath data and actually have been validated to be even better now. But again, we do have some limitations, right? Why can't we just get the same numbers? Basically, one is the phase shift because of the wedge pressure, right? There's a delay in the transmission from the change in the pressure contour through the pulmonary circulation. And of course, direct LAP is more accurate in assessing, and it can limit the error caused by the pulmonary artery wedge pressure being overestimated in cases of pulmonary venous hypertension. And it also depends on the type of the catheter we used, balloon catheter versus end-hole catheter, and accuracy of the wedging and quality of the data itself. And again, echo-derived Doppler gradient data, definitely I think CW or continuous wave Doppler has made it really easy to measure the peak velocity as long as the ankle is less of a concern. But what are the limitations, right? So these gradients do have pitfalls as they are highly dependent on both the heart rate and the flow conditions, with higher gradients being seen in higher heart rates. And the variant low flow, low gradient mitral stenosis is a less popular entity compared to its aortic counterpart, where low gradients across the mitral valve are noted mainly because of flow conditions, although it is severe. And there is some data showing higher prevalence of AFib in these patients and that almost duplication of the shadow on the outer edge. And actually, this has been beautifully described on Twitter, actually, by Dr. Rebecca Hahn, with arguments being real as a result of hydraulic forces to being artifactual from a strong reverberation signal from the double phase shift, as she demonstrated it on the CW profile of a completely normal valve, and the Doppler data was acquired using higher gains. So bottom line is, when you see something like this, use the modal velocity or the denser flow profile, and always reduce the grains appropriately to capture the denser pattern. So conventional Claymetry, again, if done accurately on decent quality 2D images, is reasonably accurate, although color-coded real-time 3D echo has been shown to be more reliable. But of course, it's limited by image quality, valvular calcification and anatomy, and 2D gain settings. And you also want to do it at the right plane, right? You want less than 1 centimeter square. The pressure at halftime. we all know how it is done, right? So definitely the time interval in milliseconds between the maximum pressure mitral gradient in early diastole and the time point where the gradient is actually half the maximum initial value. We all know mitral valve area is again derived from the conventional formula with Gorlins formula, which is 220 divided by the pressure half time in milliseconds. But again, remember the limitations, right? In cases where, the most mid part of it, which is more, good quality. And again, you want to avoid the early parts where, you can falsely actually trace the gradients. So the next famous one, right? So very important, be like in aortic valve area, you can actually use continuity equation based on conservation of mass to calculate the mitral valve area, where you actually divide the LVOT stroke volume by the VTI of the mitral valve signal. It does, however, have limitations as it involves multiple measurements, increasing the impact of errors, and cannot be used in cases with AFib or in cases with significant MR or AR. The PISA method for mitral stenosis, it does exist. Again, we don't want to go into details. It's more cumbersome and less validated, but can be used in discrepant cases. And finally, moving on to associated lesions or modifiers in some special situations. So scenario one. So this is the most common one which we face, right? When we're comparing pressure half time versus continuity equation. It is important to assess. Remember, calcific mitral stenosis is a little different, right? Because the shape of the orifice is also different. It's more tubular when compared to the typical dome-shaped and rheumatic mitral stenosis, and gradients and pressure half times are not entirely reliable, and maybe continuity equation is actually better, used in these situations. Let's show an example here, right? So we have a severely calcified mitral annulus, and we have a pressure half time of 270 with a mean gradient of 6 and a VTI of 49. So when you use a pressure half time, you get a 0.8 versus, and if you use a continuity equation, you get an area of 1.86. So this clearly shows that using pressure half time method and impaired relaxation can actually underestimate the valve area. Elevated LVEDP, on the other hand, what does it cause is because the pressure half time is, it tends to be, low, which results in overestimation of the valve area. The second scenario is, again, presence of significant MR or AR. In MR, we can't use continuity, versus in AR, you can't use a pressure. Stress echoes in patients with equivalent or discordant symptoms is important. A quick look at the stages again, we all know. And again, valve area of less than 1 comes in 2016 and has is more than 15 with exertion and more than 18 with dobutamine for severe mitral stenosis. So coming to multimodality assessment, right? Definitely use TEE when the TTE is suboptimal, and also in cases where you really want to detect left atrial appendage or LA thrombus, and also for direct, calculation of valve area, it could be helpful. In Mayes's hemodynamics, again, it's reserved for discrepancies. Again, we just talked about the limitations, and also right heart caths can sometimes be used to assess PVR. Again, I do want to defer CMR and CT assessment, although the role is limited. I do want to defer that to Dr. Nabi. Just one quick point, we all know percutaneous balloon valvuloplasty is preferred, and management of calcific mitral stenosis, on the other hand, is challenging, especially, it has poor prognosis, and it usually reserved for highly symptomatic patients, and, decalcification maneuvers are very, very difficult. Some potential promising options definitely include transcatheter mitral valve replacement within the MAC using balloon expandable or self-expanding valves. And also there's a concept of LA to LV conduits like bypasses actually in future. So a lot to look forward to. All right. Switching gears to aortic valve, let's talk briefly again about the anatomy, causes, indices of severity, and management of aortic stenosis. All right, one quick question for the audience. I kept it one. Let's see if any of the fellows want to take this. Just the picture should give you the answer. Any taker? That's aortic stenosis associated with angiodysplasia and von Willebrand syndrome. Let me just restart it. Sorry about this. All right, quick recap of the aortic valve anatomy, let's say these are embryonic remnants, are in fact increasingly recognized to cause severe aortic insufficiency, especially when thickened, because it results in tenting of the valve and malcoaptation. Bicuspid aortic valvular stenosis is an entity of its own. We are mainly going to talk about the typical calcific tri-leaflet aortic valve stenosis through the rest of the talk. Again, we all know, right? Aortic stenosis is not a benign disease. We know the classic paper from Ross and Braunwald in 1968. And since then, nothing has changed. Even in 2021, symptoms definitely remain the key element in decision making, right? So we know the average survival after onset of angina is 5 years, 3 years after syncope, and 2 years after heart failure. And remember, it's not a simple mechanical problem limited just to the leaflets. It affects the upstream left ventricle, downstream systemic vasculature. And again, there is definite robust evidence that aortic valve replacement prolongs life in patients with symptomatic severe aortic stenosis, regardless of the type or severity of symptoms, right? Our outline today is going to definitely include a brief overview of anatomy and including a focus on the etiology, some talk about a little bit of the other associated abnormalities, and what do we really do on echo to assess these patients, right? So what are the important echocardiographic characteristics we use, and what are some of the basic grading criteria, and a quick rundown on special considerations or situations. So why valve anatomy? Very important, right? Again, we really want to know about, looking at the valvular cusps is also very important. So let's start with talking about the classic paper by none other than Dr. Zogby and Dr. Q, which demonstrated the key concept of continuity equation based on the conservation of mass. So it's very important to remember how to really measure LVOT dimensions, right? It's in the zoomed parasternal long axis view in mid-systole and measured within 0.5 to 1 centimeter of the valve orifice. And this is an important step. The next step is definitely the LVOT spectral Doppler data. Again, we all know it's usually obtained in apical 3 or 5 chamber views, and all of our sonographers do an amazing job in exactly positioning the sample volume around 3 to 5 mm and just proximal to the flow acceleration in LVOT. And as readers, it's very important to really trace the modal velocity. This thickening of this, Doppler pattern, that's the profile called the spectral dispersion. It's important to avoid that. Anatomic evaluation of the aortic valve, it's actually based on both short and long axis images to identify the number of leaflets and also to look at the mobility. Direct planimetry of the valve is an acceptable alternative, but remember it could be limited because of valve calcification causing shadowing and also reverberations limiting actual assessment of the orifice. And caution is also needed to ensure that the minimal orifice area is identified accurately. Coming to other important abnormalities, right? We just talked about bicuspid valve, most common being fusion of the right and left coronary cusp. This variant is very fascinating because it has its own unique genetic and metabolic profile. But again, like I just said, we just have to skip the details about assessment of bicuspid valve on this talk. But other important things to know is also HOCM and AS, right? It limits the assessment of the spectral Doppler pattern in LVOT. Again, peak velocity is usually obtained from the Bernoulli gradient. And you all know you do not want to ignore the proximal velocity when the velocity is more than 1.5 meter per second. And again, I think this is one thing which we all, have to know it, the classic picture of aortic stenosis. And as you see, as the severity of aortic stenosis increases, the shape of the jet changes from early peaking to late peaking with prolonged, more parabolic shape and longer ejection time. And I think this table is imbibed in every neuron of everybody watching this video. We all know the criteria for severe aortic stenosis, peak velocity of more than 4 and a mean gradient of more than 40. And again, there is a special category in the guidelines called the very severe, where you use it for peak velocity of more than 5 or a mean of more than 60. And again, a valve area of less than 1 is typically severe, and with few exceptions, which we're going to talk about. And finally, the dimensionless index, a parameter which is very important in patients with normalized for body size, because a value of less than 0.25 is definitely supporting severe aortic stenosis. A quick recap of the ACC-HA valve guidelines. When define cardinal symptoms, dyspnea, angina, fatigue, heart failure, or syncope. Again, stage 1 is at-risk patients, with stage B for patients with progressive symptoms, and C and D is based on presence or absence of symptoms. Again, with AVR being class 1 recommendation in patients with stage D1, although we need to pay attention to reversible causes. Another one is the definite low flow, low gradient classic. That's the classic low flow, low gradient severe AS with definition of LVEF of less than 50%. Or again, the paradoxical one where you have the EF is preserved. However, there is a low stroke volume index of less than 35. Again, first, like we said, we really want to cross-check the. And a brief statement about low flow, low gradient. So one thing, remember, you can really start with a low dose of dobutamine at 2.5 and gradually increase. There is contractile reserve. And severe stenosis, again, we know is defined as once the velocity hits more than 4 or the mean gradient is more than 40, provided the valve area does not exceed more than 1, is also suggesting severe AS. And absence of contractile flow reserve, it's actually very important. It predicts high surgical mortality with this, and he's normotensive at baseline, like you see. So if you see the valve is significantly thickened and calcified, and we measure the resting gradients, to be in 2.7 peak velocity with a mean gradient of 30 and an AVA of 0.7. Now, you see the EF is marginally increased with dobutamine. And what about the valve parameters, right? So now the LVOT VTI has increased from 16 to 23, with the stroke volume increasing from 45 to 66, which is approximately 30%, right? And now the peak velocity is 4 with a calculated valve area of 0.8. So I think this is pretty, obvious. This is obvious low flow, low gradient severe AS. What about scenario 2? So what if the VTI is increasing from 12 to 20? Now the peak velocity is still 3, and the valve area has increased from 0.8 to 1.4, and this is definitely not severe, right? So it's simple, but you just have to look at all the parameters. And the last one, I think, very important, like low flow, low gradient, normal EF1, right? So the paradoxical one, very important. It's actually described as a conundrum. Again, like for multitude of reasons, it's like ranging from small ventricle, pronounced concentric remodeling, and also when the flow is going in the wrong direction, right? If there is significant MR, the transvalvular flow across the aortic valve is going to be low. And bottom line is, like Dr. Zagbi suggests, I think this is a very important read for every fellow. So trust, but verify your number. I think this is a must read for all of us. Let's look at a quick case example. We have a 90-year-old small hypertrophic, ventricle. You see that, and you see a peak velocity of 3.5 and a calculated valve area of 0.59. Again, you see a stroke volume of 31. So this again reiterates the need for careful assessment and reevaluation if needed. So the final summary, I should say, definitely, go through both the velocities and the gradients, assess the aortic valve area and exclude high flow status. And once we have established this, then definitely define, what is, errors, right? Like go back and make sure that you're remeasuring your LVOT and reassessing one more time the LVOT spectral Doppler profile. And once that is established, and once you divide them into low flow versus normal flow, you really want to consider the dobutamine and also assess for true severe versus pseudo severe AS. And one important thing I think is the most powerful tool these days we have is the calcium score by CT. I'm sure Dr. Nabi is going to talk more about it, but it has a lot of role in in assessing true severe AS. One important echo tool, which we do not want to ignore, definitely, is also myocardial strain, and specifically the GLS. And I think the recent meta-analysis by Magni et al. Highlighted the role of GLS in survival. And this definitely showed a cutoff of 14.7% being a predictor of poor survival both at 2 and 4 years. And it could be actually considered a trigger for future investigations and images. And one other concept is also aortic stenosis and cardiac amyloid, particularly in those patients with paradoxical low flow, low gradient. Again, there is, concept of amyloid infiltration of the valve leaflets resulting in faster progression. And, I think there's a lot of talk about, how this is an important masquerader in the assessment, and it could have important therapeutic implications in future. Another one, diastolic dysfunction, as described by Dr. Naga as a partner in crime, very important in predictor of clinical outcomes. this study, by Ong et al., definitely showed that, first of all, as the severity of diastolic dysfunction or the LV filling pressures increase, the degree of hospitalization and death basically increases even at 12 months, suggesting that the prognosis in aortic stenosis is beyond the valve. All right, finally, I coming to a quick summary. So first of all, I would say echo first, and I think echo Doppler remains the first line modality for both assessment of aortic and mitral stenosis. Attention to details is very crucial. And finally, integrating the imaging is very important, right? Look at symptoms, 2D findings, and Doppler findings. And one crucial point, I think, which Dr. Zagbi also mentioned recently, and how it's very important to think beyond the valve, right? How there's a lot of data about how, you want to restage aortic stenosis based on the extent of cardiac damage. So, I think, we are really moving towards that direction now. And finally, thank you so much for all your attention. Please reserve your questions to the end as Dr. Nabi is preparing to take us through the world of CT and CMR and valvular stenosis assessment. Thank you, everyone.
Okay, good afternoon, everyone. I'm Faisal Nabi. I'll be speaking on the application of CMR in valvular stenosis. So as Bindu very nicely told us, really echocardiography, there's no doubt, is the initial test for patients with valvular heart disease, and oftentimes the best test for serial measurements and follow-up as well. However, echo does have its challenges. There can be cases where image quality may not be optimal. You can have difficulty determining specific morphology of the valves. You may not be able to assess Lvot diameter well. For when it comes to Doppler, maybe you're not able to perfectly align with blood flow. And definitely you cannot completely visualize the aorta. And sometimes, as she very nicely detailed as well, is you have discrepant information between 2D findings, Doppler findings, and patient symptoms. Now, classically, what happens in those situations are patient will then go to one of two invasive tests, either transesophageal echocardiogram, where they'll have planimetry done, or you'll go to the cath lab and have, have a aortic valve area calculated through the Gorlin formula. But my job today is to suggest to you that we have an alternative test, such as cardiac MRI, which can be very complementary to echo and has a lot of strengths that we've touched on before, and I will during the course of my talk, which can help you evaluate patients with valvular stenosis further. So here's a little bit a diagram of some of the different subjects of aortic stenosis with CMR that I'll be addressing. And so, what I'd hope to address is to teach you a little bit about what we can learn about the left ventricular morphology, moving on to aortic valve morphology, how we calculate anatomical valve area and peak antegrade velocity, looking at two features with CMR that really are not provided by any other non-invasive test, and that specifically includes the assessment of myocardial fibrosis, and then the ability to also completely visualize the aorta. So let's talk a little bit about LV morphology, specifically volumes, mass, and function. So here's a classic example of an MR done for aortic stenosis. I hope you'll be able to appreciate, we get all the consequential echo views, short axis views all the way from the base to the apex, as well as your traditional long axis views. And here you can see a very calcified, immobile aortic valve and flow acceleration at the level of the valve. All of you who have seen cardiac MRI reports are very used to getting volumetric data. And in this particular case, you can see here that the patient's biventricular sizes compared to reference normals is normal in size and function. that the patient has concentric hypertrophy present, and ejection fraction, again, were both normal. But what I really wanted to stress, and which has been stressed in other talks as well, is when it comes to the assessment of LV volumes and ejection fractions, remember that this is really the gold standard technique, cardiac MRI. And we've discussed how we do this in the past. And basically, you're tracing the ventricle in diastole and systole. There's no geometric assumptions that are made. And knowing the difference between your end diastolic volume and your end systolic volume, that's your stroke volume. And if you divide that by your end diastolic volume, you're getting your ejection fraction. Similarly, if by simply, we can also determine myocardial mass. And here again, as I had shown you, this time, in addition to the subendocardial tracing, we also trace the epicardium. And then the volume difference between the subendocardium and the epicardium becomes the volume of your myocardial mass. And then simply multiplying this volume by the myocardial density, you're able to now quantitate the amount of mass that's present in your myocardium. Now, a couple of important points. We include the papillary muscles as part of the myocardial mass. And again, this is completely free of any geometric assumptions, as we're tracing the entire ventricle from base to apex. From echo data and also CMR data, which I won't share with you today, but I think we're all very familiar and comfortable that really LV mass is very important to know, as it's an independent predictor of cardiovascular events. And again, studies have clearly shown, because of its reproducibility, that cardiac MRI really is the gold standard when it comes to mass assessment. Now, classically, from echo, we have learned that there's 4 ways of remodeling the heart in patients who present with pressure overload, and that's including the concentric remodeling and concentric hypertrophy, as well as the patients who have either normal or have eccentric hypertrophy. But, in an important study that was published a few years back, this group actually showed that there's actually 2 other forms of hypertrophy that remodeling that we should be aware of. And this is what we call asymmetric remodeling. And this actually occurs in about 27% of patients. So another very common form of remodeling that we can see is asymmetric remodeling, where you actually see differences in dimension size between your anterior septum and your posterior lateral wall. Now, why do I mention this? Because we already know those 4 traditional patterns are associated with increasing cardiac events. But it turns out this study also shows you that these asymmetric ways of remodeling also, unfortunately, have a poor prognosis. And this study, again, they came out with almost 26% of patients had this asymmetrical wall thickening. And you can see here, those patients who had this in the blue line had worse survival than those with more normal, who did not have any evidence of remodeling. This study also went on to show us that there is no relationship between the valve area and how the patient will remodel their heart. And it really kind of explains why there's so much heterogeneity between the severity of valve stenosis and symptom onset. There has been a lot of recent insight looking at sexual dimorphism as to an explanation of why patients remodel the way they do. This was a patient with asymptomatic moderate to severe aortic stenosis that showed that men in general tend to increase their LV mass, whereas women are more prone to have concentric remodeling. All right, so what other information can we drive with our CMR? Of course, another very important piece of information is determining about the aortic valve morphology and being able to determine anatomical valve area. So, with a large field of view, the ability to zoom into any object or structure that we want, you can see with great clarity how we can see different types of valve morphologies. Here's your traditional tricuspid valve here on the far left. Here are examples of bicuspid aortic valves, the classic Severt 0 and the Severt 1. And then finally, some other types of valves which you may not have had the opportunity to see. The unicuspid valve, which kind of looks like a volcano, and then finally a quadricuspid valve here where you can clearly make out the four cusps. So really, you have with CMR tremendous opportunity to very clearly understand the morphology of the aortic valve. When it comes to determining valve area with CMR, this is we actually planimeter a valve area. And so how do we go about doing this? Well, the way this is done is you usually have two long axis views of the LV outflow tract and the aortic root. Then using a double oblique pattern, you're able to create a true short axis of the aortic valve, and you create a stack of these in serial. Once you've created a stack, you can very easily make out the morphology, but more importantly, you're also able to then planimeter these different images that you're able to produce. And the valve area is really the smallest maximal systolic opening that you planimeter at the leaflet level. So here you can see very nicely the yellow line represents the leaflet tips. This is the cross section of the aortic valve at that location. We trace on the inner edges of the leaflets, and you're able to planimeter a valve area. Now, I think, traditionally, how does CMR fare with other technologies? These were two important studies that I think people should be aware. Multiple studies looking at CMR versus TEE. And you can see here that really there is no difference in the measurements that are obtained between cardiac MRI and transesophageal echocardiography. And similarly, when they compared CT either to TEE or CMR, really the measurements by planimetry by any of these techniques were all very, very similar. Now, I think it's an important point to highlight over here that the measurement, the valve area that we report on a cardiac MRI or a cardiac CT report is different from the measurement that you see on a traditional echo report. The valve area, again, by echo, CMR and CT is a planimetered valve area and is actually a measurement at the leaflet tips, whereas the measurement of an effective orifice area that you get by the continuity equation is actually a measurement that defines, where the vena contracta of that peak velocity is. So very important to understand that with a planimetered valve area, it's an anatomical measurement at the leaflet tips, whereas with the effective orifice area by the continuity equation, this is really at the vena contracta, a slightly different location. Now, how does the planimetered valve area compare to a traditional physiological valve area? And these were several studies that have looked at this, and in general, basic message is that the planimetered valve area is slightly larger, about 10% or 0.1 centimeters squared, compared to the valve area that's obtained by the continuity equation. So what does that mean when you're interpreting a cardiac MRI study? So what it does mean is, although we have no prognostic data with anatomical valve area by either CMR, CT, or TEE, unlike what's obtained with the continuity equation with echo Doppler, I think it is fair to say that if you were to planimeter a valve area less than 1 centimeters, because this planimetry is larger than the effective orifice area, that you have a very strong argument that your patient does truly have severe aortic stenosis. We can, using software, quantitate a continuity equation, valve area with CMR. However, this takes a little bit more time, and you have to have the appropriate software available. What about special scenarios such as as we had talked about, the low flow, low gradient, reduced EF, severe AS? Obviously, if you were to planimeter a valve area here, the number will be underestimated and really does not tell you whether this patient truly has true severe aortic stenosis. We can do a cardiac MRI dobutamine study. However, giving dobutamine and, in the MRI environment for prolonged periods of time does have its own intrinsic challenges. But what kind of role can CMR play in these types of patients? Number one, it can definitely confirm the low flow state using the different quantitative features that we have. We can definitely get a very accurate assessment of the ejection fraction. And definitely we can look at the underlying myocardial substrate using LGE T1, T2 mapping. As you know, as was previously shown, that 16%, TAVR studies have shown that up to 16% of low flow gradient severe AS patients have underlying occult cardiac amyloidosis. So CMR can be very helpful in these patients identifying, diseases of the myocardium and as well as confirming the low flow state. What about those patients who have low flow, low gradient paradoxical severe aortic stenosis? Here, CMR really does not have a role. Rather, it is cardiac CT. And as per the guidelines, it's a 2A recommendation to get an aortic valve calcium score. And you can see nicely here in this table that if a female has a score greater than 1300, this is very suggestive of severe aortic stenosis in this scenario. And then for a male, it's a score greater than 2000. So here, a non-contrast CT, simply to measure the degree of calcification at the aortic valve, can help identify those patients who really truly have aortic stenosis versus a possible measurement issue, as Dr. Chebrolu had mentioned. Let's move on to antegrade velocities. We also have a version of echo Doppler, and that's called phase contrast images. These are our phase contrast images. You can think of it just like echo Doppler. It's a velocity map. What we do here in order to determine a velocity going through the valve leaflets, unlike echo, we have to be perpendicular to flow rather than to parallel to flow. So what we do is similar to how we create a short axis at the valve leaflet tips for planimetry. Using our long axis slices, we identify the vena contracta of the aortic velocity jet, the point of peak velocity. We create a double oblique at that location, and we create a through plane image at that slice location. And this is what's then used for quantifying velocity and flow. It's really the through plane images in cardiac MRI. Now, important point to note is, so how do we go about actually determining what the velocity is? With MRI, you actually have to input what the maximal velocity the computer can see. So in this particular case, a maximal velocity of 3.75 led to what we call a lot of aliasing in MR images, where you have both black and white in the same image. This is representative of the fact that the velocity is greater than 3.75 and is aliasing in this image. Hence, for each, whenever our technicians see this, they then go on to increase the VENC setting on the computer until there is no aliasing pressing. And the peak velocity is identified as that peak velocity where really, and there is the lowest velocity where there is no aliasing. So in this particular case, there's aliasing. So here at 4.25, there was no aliasing. This would be then the peak velocity through this aortic valve. We have sophisticated software where we can, try to really pin down what the exact velocity is. In general, I want y'all to know that, this has been looked at compared to echocardiography, and you could see in general, there tends to be very good agreement. However, it is important to note that for several reasons, and for the sake of time, I won't go into, but most importantly, because of lower temporal resolution, our temporal resolution is 40 milliseconds, whereas that of echo Doppler is 2 to 3 milliseconds. You can understand we would miss the very peak velocity. And so in general, we tend to underestimate velocities. And similarly, like with the valve area, I think, if you were to get a velocity greater than 4 meters per second in your CMR report, this really is a strong argument that your patient, again, has severe aortic stenosis. There's a lot of hope for 4D flow. As you know, 4D flow is looking at velocities in all three directions. You're getting a volume of data. This is one study that showed that if you look at 4D flow velocities compared to echo, they actually were very similar in comparison. So this could be, one opportunity in the future where we can really look at flows and velocity very accurately. Now let's move on to the trunk card of CMR. Of course, this is one technique that that is the only technique that can show us myocardial fibrosis. As you know, really endocardial biopsy is really the gold standard when it comes to fibrosis. We know in patients who have gone on for AVR that doing a core biopsy of the septum and determining the degree of fibrosis that's present on those samples portends what the patient's prognosis will be. But isn't it great that we have a technique with cardiac MRI where we can look at two types of fibrosis? We can look at replacement fibrosis with our LGE sequences. Replacement fibrosis tends to be a focal process. It tends to occur late in the disease and is an irreversible process. Another way to look at fibrosis is to look at interstitial fibrosis, which can be easily not seen in your LGE images. This is picked up with our T1 image maps and by another technique which uses post-T1 images maps with contrast, and that's something called extracellular volume fraction. So the combination of T1 and ECV can help identify this diffuse interstitial fibrosis, which is diffuse in nature, tends to occur early, and is actually a reversible process. The types of replacement fibrosis that we see, we can identify in AS, we can see patients who have subendocardial infarcts, but specifically scars that occur from AS are this mid-wall fibrosis, and they can occur anywhere, here in the lateral wall, here in the septum, here in the infralateral walls, and pictures E and F. And what studies have shown is that if you have a patient who has this mid-wall scarring, compared to those patients who do not, identifies a cohort of patients who actually have very sick hearts. These patients have big ventricles, they have a lot of LV mass, and they have lower ejection fractions. And sure enough, if you looked at a large core of patients for survival, you can see here that any type of scar is bad news for your patient. So we always knew having CAD scar is bad, but in aortic stenosis patients, you can see here the non-infarct mid-wall scar portends equally bad prognosis. In this particular study, you can see almost 51% of patients of aortic stenosis patients will have scar and portend worse prognosis. Again, just a reminder slide, that, when we're looking at the myocardium with LGE, it can be very helpful in your low flow, low gradient patients, who about 16% of which will have underlying cardiac amyloid. Now, this is just a graph going back to show us that, for those patients who don't have replacement fibrosis, LGEs will be normal, but using T1 mapping and ECV fraction, and this is really talks for another day, we can really quantify the diffuse early reversible fibrosis. And this is, the ability of CMR to do this, you can see here compared to core biopsy samples, both ECV and T1, as they increase, there's a reasonable correlation with increasing degrees of fibrosis seen by histology. And studies have also shown, both for native T1 as well as for ECV, as your T1 values increase or your ECV increases, your prognosis for the patient. And these are hard endpoints. Overall survival, mortality are significantly decreased. So, any type of fibrosis, whether it's early and reversible or late and irreversible, tends to portend a very poor prognosis for your patient. And so this just gives you a slide that, as we learn more about these diseases, we're learning that there's that type of aortic stenosis where, the myocardium will be completely normal. There's a type of aortic stenosis where you'll have just expansion of the interstitial space by ECV and T1 values. And then there's the type of aortic stenosis which will progress further from the extracellular expansion and actually have replacement fibrosis and presence of LGE, delayed hyperenhancement on LGE. And you can see here as your disease state progresses, all these parameters of LV mass, troponins, diastolic dysfunction, peak velocities, outcomes all progressively worsen. Another point to highlight, it's important to realize that, AS is not just a disease of the myocardium, it's really a global disease. And, this was very nicely shown in the echo literature, how progressively, there's damage, going backwards, and your stage of your disease really predicts your prognosis as well. A lot of effort is being put into these patients who we're learning about having, ventricles that are not happy, maybe trying to intervene on these patients earlier to see if we can impact prognosis. These are a TAVR trial and also cardiac MRI's EVOLVE trial. These are all currently enrolling, and we look forward to seeing what their results will show. There's also a lot of data on myocard CMR and looking at remodeling post-AVR. I won't spend too much time, but no, in general, this is kind of what you'll see is once the patient has aortic AVR, we've seen regression in myocardial mass and the diffuse fibrosis. But unfortunately, once you have replacement fibrosis, that's an irreversible process, and that remains present with you. All right, so finally, CMR and CT both afford you the only opportunity to look at aortic assessment. As you know, a lot of these patients, specifically with aortic valves, bicuspid aortic valves, have issues with aortopathy and possibly coarctation. Cardiac MRI, we can get really, using MRAs, really beautiful images of the entire aorta, done completely without any radiation. We can make very accurate measurements of your root and very accurate measurements of all portions of the aorta using the correct way to do things, which is a double oblique, external border to external border. So really allowing for consistent measurements. And this really has important considerations because, as you know, in the guidelines, if you have a bicuspid valve, there are different values you have to remember when you should be considering possible concomitant aortic surgery. There's a lot of interest also in 4D flow and the aorta. We know 4D flow, as we had discussed, can be great for velocities and flow, but we can also use that for looking at wall stress. There's been a lot of studies in bicuspid aortic valves showing that where the jet hits the portion of the aorta, there's a lot of wall stress there, and histological studies have shown a lot of increase in extracellular matrix dysregulation compared to the opposite side. And this may be the reason why patients go on to develop these aortopathies. Know that with both techniques, CT and CMR, that we can really, are really the standards for performing accurate measurements for patients who need transpercutaneous valves. When it comes to mitral stenosis, again, this is Dr. Chebrolu is absolutely right. This is better assessed with echo. We can do planimetry, but this is an actively moving valve oftentimes, and we really have to make sure that our slice location where we will planimeter is truly at the leaflet tips and not at a different location where we could easily overestimate the true planimeter dimension. So studies have shown, at least in with CMR, that it can be a reasonable technique if you need to use it. So my final summary is above. For the sake of time, echo is really the cornerstone. CMR is becoming a very good alternative to these invasive techniques, especially when echo results are equivocal. Really, its strength is going to be myocardial fibrosis as a marker of decompensation. A lot of trials are looking at that to identify patients who could benefit from earlier surgery, even if they're asymptomatic. And then finally, when you need a complete evaluation of the aorta, both these anatomical techniques, CT, CMR, can be very helpful. All right, thank you. I appreciate the opportunity to speak to you, and Dr. Chebrolu also does as well. And
thank you everyone for being with us, and stay tuned for next week.
If there's any questions, we will be happy to answer here in the next few minutes. Well, all right, everybody, have a safe rest of your Tuesday, and we'll see you next week. Bye-bye.
Take care. Thank you.